Hello and welcome to Health Affairs This Week. I am your host, Jeff Byers. It's August 28th, 2024, and today we'll be talking about universal basic income and the social determinants of health. Before we begin, just a quick note, we will be releasing a new issue next Tuesday. Key articles include research on access to care and coverage. You can listen to some of the authors discuss their work on our other podcast, A Health Podyssey, which includes interviews with journal authors with our editor-in-chief, Alan Weil. Those episodes drop every Tuesday, and you can pre-order your September 2024 issue of Health Affairs today. Today, I am joined by Seth Berkowitz, Associate Professor at UNC Chapel Hill. Seth notably was a previous author on our Health Affairs Insider newsletter on social determinants of health. Today, he joins me. He recently authored a book called Equal Care, Health Equity, Social Democracy, and the Egalitarian State. He's here with me to discuss the book and the concept of universal basic income, which was a main idea in the book. Is that about right to say? Is that a main idea, or am I reaching there?
I think it's covered in the book. I wouldn't. The book probably doesn't focus on it, but I mean, it's certainly fine to say, one of the ideas discussed in the book or something like that.
Well, fantastic. First, Seth, welcome to the program.
Yeah, thanks so much. I really appreciate you having me on.
Yeah, so maybe not quite as elegant of a transition, but as far as like what's the main concept of not, maybe it'd be a great idea if you could just give us a brief overview of your book and why you wrote it.
Yeah, thanks. So I think the reason that I wrote the book was because in my day-to-day work, so I'm a primary care doctor. In my clinical work, I'm a researcher, and so work on studies about trying to address health-related social needs and things like that to improve health. But it felt like there was really sort of a bigger picture there. And though I think a lot of these interventions that I and other folks work on are promising in terms of sort of mitigating some of the consequences of adverse social determinants of health, they're not, kind of directly getting at what the real causes are in some ways, which are, I think rooted in social policy and the way we distribute resources and power in the U.S. And so I felt there was just sort of a bigger picture to, talk about health equity topics, talk about social determinants of health topics, talk about how social policy can influence these things, and to really kind of put all the pieces together. I sort of think of the book as being in three parts. So the first part is sort of a normative argument. It talks about sort of current health equity work, gives a little bit of a critique for some of the approaches that I think are commonly used in health equity work right now that are not necessarily wrong, but I think are not necessarily pushing us in the right direction either and could be improved on. And then sort of gives a grounding in a view of fundamental moral equality that the state, that our government has a duty to make sure is substantive. So sort of put us in conditions where we're standing in a relationship of equality with other people, where some people's lives don't count for more than others. Some people don't have, undue power or control over other people. So that's sort of the first part that, covers a lot of current health equity work, and then also, normative philosophy, political philosophy, and those kind of things. The second part is sort of the more empirical part. So it's a description of how injustices that we experience, inequality in our lives, leads to unequal health outcomes. So it tries to put together a lot of different epidemiological theories and empirical evidence showing just how these social conditions harm health. And then the last part of the book is sort of the practical part, and that's about how to use social policy to improve health. So what should the goals of social policy be? How do you actually make them run from a, just sort of a feasibility, implementation, public administration standpoint? How do you finance them? There's a whole chapter on, taxes and things like that, which, for me as a physician was, a little bit out of left field, but I think it's really important if you're talking about these proposals that you have sort of a sound approach to actually make them work. And then there's just sort of a lot of practical pieces in there about like, all right, what are our current, structures of social insurance and social assistance programs look like, and how can we make them better and better able to help improve population health?
Yeah, great. Thanks for that. I'm currently working through the book myself. One thing that you bring up early on in the book that I thought was really interesting was that you note health equity work to avoid political confrontation over social inequality risks accepting and even normalizing the production of health inequity. I thought that was really provocative. Can you walk us through that statement?
Yeah, I mean, I think the idea there basically, and I think from someone who grew up in the '80s and '90s and has had my career sort of start in the late 2000s and continue to 2010s during a period of time where it just seemed like major social policy changes just kind of weren't on the table politically, and so the advice was, yeah, we know that these social conditions are harming health, but there's just not going to be big political change in the U.S. There's no appetite for it. And so, what we need to do is kind of work to mitigate the consequences of it, which I sort of, said earlier in some ways. And I think that's valuable work, right? I mean, if things are out there harming people, and you have the ability to make things a little bit better in a clinical encounter from a health system perspective or something like that, by all means, like go out and do that. But the more that I've been as involved in things like that, the more I was worried that we're losing sight, like that there were these causes out there. And so if your whole view of health equity work is just to kind of mitigate the consequences or pick up the pieces or respond after the fact, and none of it is about actually trying to figure out, well, specifically what is causing this and what can we do about it and how can we make it so that people aren't in these situations in the first place, then I worry that that's that sort of normalization that says, yeah, it's okay that the U.S. has a high rate of food insecurity. That's just how it is. And if you have food insecurity and you come to clinical attention, then we'll have a program that tries to address it, as opposed to saying, well, wait a minute, why is food insecurity twice what it is in the U.S. than in other kind of similar countries with similar economies and those kind of things? Why is that happening? And so that's sort of what I meant by that phrase, that if we don't keep at least our eye to some extent on what's causing these things and don't view challenging those causes as sort of a fundamental part of health equity work, then we may be missing the bigger picture.
Great, thanks. And I know we're going to talk about universal basic income, and I'm going to ask about a policy question based on the framing of what you just said about social policy and risk and normalization. The main thing that just came up for me as you were talking about it was like, how do you place the Affordable Care Act?
I think the Affordable Care Act was an important incremental change in the way we make healthcare accessible in the U.S. I think overall, compared with many other countries, I think the way that we make healthcare accessible in the U.S. has some serious shortcomings. That said, it's sort of an embedded system at that point, and it's kind of not easy to change from that. There's a lot in the ACA, but two of the major planks were Medicaid expansion and then the ability of people who weren't covered by insurers and weren't covered by Medicaid to buy insurance on the private market, the ACA exchanges. Medicaid expansion, I think, has been a big win overall. It's gotten a lot of people covered. There have been a lot of studies, many of them in Health Affairs, about the health benefits of that. The exchanges, I think, have been useful, but are on a relatively small scale. But no doubt there are also plenty of studies that I think have shown benefits from people who are able to gain insurance coverage that way and otherwise would have been left out. And so I think it's been helpful for them. I will say we now have probably stalled out roughly in what the ACA is going to accomplish in terms of healthcare coverage. We're still at around somewhere in any given year, 5 to 10% of the American population is not covered. If there are about 10 states that still haven't expanded Medicaid, but could under the ACA, and it would help a lot if they did. Proud to say North Carolina, which is one of the holdout states, expanded Medicaid at the end of 2023, and so that's definitely been a big boon, and we're starting to see benefits there. So I think there are important things there. I think it's also always important to say, even though I think it goes against my socialization as a physician and other things as well, is that healthcare is obviously very important for health, but it is certainly not the only thing that matters for health. And some people can make a very good argument that other things matter more. And so even if we were able to get to universal healthcare access through further reforms of the ACA or even more thoroughgoing reforms, Medicare for all or something like that, that still would not, be the be all end all for all our health equity woes. There would still be a lot of other things that we need to deal with. So I think it was definitely, better than the way things were before, in a number of ways. I hope that it can continue to be improved upon. I definitely don't think we should go back to the way things were pre-ACA, but it's going to be at best a sort of partial solution, I think.
Right. The tanning tax didn't solve everything, is what you're saying.
Right.
Yeah, great. Thanks for that. Going to universal basic income, it is one of the ideas, main plot point or not, that you explore in your book. For those that aren't aware, what is universal basic income and how can it address health equity?
And so I think universal basic income, or UBI, I might abbreviate a little bit, is I think a really exciting idea. It's galvanized a lot of attention that I think is really important, and I think even aside from the policy specifics of it, I think has galvanized a lot of attention about the role of income support more broadly, and you might structure that in different ways, and how that might influence health. Terminology gets used in a lot of different ways, and I'm definitely not the language police or anything. The way I think about it, I think of UBI as a subset of what I'll call guaranteed income. So I think of guaranteed income as income that is, it's transfer income, so it's received without the exchange of goods and services. So, it's a government check or something like that. And guaranteed income, I think, is generally not conditional on factors. So it's not necessarily means tested. You don't have to establish that your income's below a certain level. It's not, based on categorical eligibility. You don't have to show that you're above retirement age or something like that. It's just sort of income for everyone. A subset of guaranteed income, what I think of as UBI, universal basic income, and that is income that's kind of sufficient for a decent standard of living. And so that sometimes gets operationalized as like a poverty threshold or something like that. So it's enough income that could potentially be your only source of income, and you would still have a reasonable standard of living. So guaranteed income overall might be any amount. It might only be $100 a month or something like that, not enough to live on. But UBI, the way I think about it, at least although terms don't always get used exactly this way, is guaranteed income of a sufficient amount that it's a living. It would provide a reasonable standard of living. So then that brings to a big picture question around health equity in general is the role of income and health. Now, it's absolutely the case that income and income distribution is not the only reason for health inequity. It's absolutely the case that there are many forms of oppression and marginalization that do not work through income pathways. And even if incomes were completely equal, which is not a policy that anyone's proposing, there would still be other ways that health is harmed through injustice. But I think there's a very clear relationship between income and health, in particular that lower income is associated with worse health. I think it's one of the most robust findings in all of social epidemiology. And there's a very plausible mechanism for that, right? So in general, to be healthy, you need to consume goods and services, healthy food, healthcare, quality housing, and income provides the purchasing power for a lot of those goods and services that are allocated on the market. And so when you have, income maybe above some threshold or a higher level of income overall, it's easier to afford healthy food, it's easier to afford healthcare and all these things. So ensuring that people have sufficient income is a really key part of population health overall. And if there's substantial income inequality, in particular, if there are a lot of folks with lower incomes, they're likely to be much less healthy. And so that will create health inequity. So then the question is, all right, well, how should we get income to people or sort of, make sure that people have sufficient income? And so UBI is one approach to doing that. Other approaches I will sort of broadly call social assistance. So these are sort of means-tested income support programs like TAMP or SNAP, the Supplemental Nutrition Assistance Program, food stamps is what it used to be called. So these are income support programs, but only for people below a certain income level. So they're means-tested. EITC, Earned Income Tax Credit, is another one. Social insurance is income support that's provided on the basis of being at risk for insufficient income based on the social situation you're in. So retirement is a time that people may be at risk of insufficient income because you're no longer working. And so we have social insurance programs like Social Security's OASI, Old Age and Survivors Insurance, the sort of standard Social Security checks that we think about. Unemployment is a time when people are at this risk, and so we have unemployment insurance. If you have a work-limiting disability, that's a time of risk, and so we have SSDI and SSI, Social Security Disability Income, and Supplemental Security Income as ways to provide income assistance in those cases. And so social insurance is sort of another approach to doing that, and then UBI is sort of a third approach that says, well, look, we're not gonna make you prove an income level, we're not gonna make you be in a particular situation. We're just going to distribute income. We know you need it, and we'll do it that way. It'll be a lot simpler. And so that's the approach. And so to the extent that UBI gets income to people who would not otherwise have it or would otherwise have an insufficient level of income, then I think it can have a really important health equity benefit. The sort of rub in the program is the same simplicity of it, which is that like income goes to everyone, also means that it's going to go to a lot of people who probably would not have low income even if they weren't in the program. So what that can do is tend to dilute some of the overall impact of the program. And I think we saw that in some of the recently published results from the Open Research, Sam Altman's Open Research Organization, and that UBI study.
I was going to ask you about that UBI study. It made some headlines recently. In some ways, it's regardless on anyone's thoughts on AI, and also I don't want it to be too cynical. Of like, I think the report was funded to see under the assumption that jobs will be lost because of AI, and maybe that's a cynical thought. But regardless of your thoughts on AI, what does this study show on UBI, and how does it relate to health?
Yeah, so this is a great question. I think it was a really impressive research effort that they pulled off. Number of papers that are out there. One focusing on health, one focusing on labor market impacts, one focusing on consumption, and I'm sure they have more planned. So that study, I view as more or less being along the lines with what you might have expected from just sort of a theoretical thinking through of what's likely to result from AI. So in that study, they took not super low and not super high income folks. So I think you had to have an income. I think they had about a third of their sample were below the sort of official poverty threshold. About a third were in 100 to 200% of poverty threshold, and a third were about 200 to 300%. So sort of a distribution of lower incomes. They found that there was an income differential created between the groups. So on average, if you also include the both the income that people earned and received in that way and the income that they received as part of the study, the people in who received the UBI had about $8,000 per year higher income at a household level. But the income levels of both groups went up pretty considerably from baseline in the study. So at baseline, I think both groups were right around $30,000. And by the end of the study, both groups were around $50,000, 50 to 60, somewhere in there. This also sort of coincided, and they couldn't plan this, it's just what happened, with the sort of pandemic era expansions of what you might call the welfare state and other social insurance programs. So there was pandemic era unemployment insurance, more Medicaid accessibility, stimulus checks, more higher SNAP benefits through the emergency allotment program and other things. So there's kind of a lot of income going around even outside of what they were providing. And so basically they had I'd say a modest differential in income at a relatively high mean, although that's not the whole distribution, and more or less didn't find large differences between the groups. The group that received the UBI worked slightly less, like on the average of like an hour a week. And that was mostly concentrated in, sort of particular subgroups. So it wasn't like everyone worked less, but even still, it was, a small difference. There weren't a lot of health differences for people. So I think they initially did see pretty large reductions in food insecurity, but a lot of other health, depressive symptoms and those kind of things had maybe some small benefits in favor of UBI, but not sort of big differences. And again, I think, based on what we were talking about earlier, I think a lot of that is more or less what you may expect, thinking about, well, what is the relationship between income and health, i.e., it helps you buy the goods and services you need to be healthy. And then what is the situation that people are in the counterfactual, in the absence of the program. In this case, the comparison group didn't have particularly low income, and so they may not really have been at very high risk of, having their health impacted by low income. And then so adding additional income into that situation didn't necessarily have a large impact on health. All that being said, this is a 1 to 2 year follow-up. We think of health as sort of, developing across the life course. There's a whole field called life course epidemiology that looks at things that are developing over 20 years, 30 years, 40 years, and things like that. And so definitely not the end of the story or anything. But yeah, that's kind of my basic takeaway so far. Caveat with all of this is that, the papers were recently released. They're very long. I've looked through them, but probably not as much as they should be. And still, they'll go through peer review and there'll be other things as well.
I'm trying to figure out where we go from here as we want to begin to bring our conversation to a close. You mentioned the COVID-19 pandemic. That also makes me think of when the government gave us a decent amount of money which I thought was interesting. In a way that it kind of shows some Keynesian theories and implementations. Is that? Do you have any takeaways on that?
Yeah, I mean, I think a lot of the social policy that we did during the pandemic, or sort of maybe I should say the height of the pandemic. Obviously, COVID is still with us and going on now. What I think really should be a big model for what we do going forward. I think we learned a lot about what was helpful there, in ways that are health improving, and just sort of well being improving, overall. And so there's a lot to take away there. A couple of key things that really stood out for me. One, we really substantially reduced food insecurity. At the start of the COVID pandemic, we had the largest contraction in GDP since the Great Depression era or something like that. Very high unemployment, all this stuff. This should be a recipe for very high food insecurity, and food insecurity is something that I do a lot of research on. And it did not increase. We kept it stable in 2020. We kept relative to 2019. We kept it roughly stable in 2021 relative to pre-pandemic, and then it only increased in 2022 when we wound down a lot of our programs, and then we saw the largest increase, of the last 20 years or more. So I think we had very effective policy in keeping food insecurity in check during the pandemic. So that was really good. Similarly, with poverty measures, we did not see an increase in 2020 or 2021. When if you look at the macroeconomic conditions, you would expect that poverty would spike. It didn't when we wound down the programs, even though, again, by macroeconomic indicators, the economy was doing much better in 2022. We saw a big jump in poverty, I think, because the programs wound down. And also, I think to your point about some of the sort of Keynesian and stimulus effects and those kind of things, I think are really important. It's really important to look at how the U.S. did compared with other economies. So U.S. GDP growth since 2020, I think, has been about 8%, something like that, and most other European economies have been at best. I think Italy is one of the best, and they were maybe 4 or 5%. The sort of European economic stalwarts, Germany, France, and those are maybe like 2 to 3%. I think the UK might actually even been smaller, although maybe there's some Brexit effects there. So the US did very well compared with other economies coming out of it. Again, I think as a result of our policies that definitely had a demand stimulating effect.
And to bring it to a close and kind of go back to your book, actually, as you were talking, I was thinking about, so there's an intervention, let's say it's UBI, and that intervention is to help with food insecurity. And that's, another dot in the line of trying to help health. So there's a lot of cause and effects that has a very long tail here when you're talking about these things. And so I guess with that in mind, and I don't want you to give away your book by any stretch of the imagination, but when you think about the long tail and the multi-prong or multi-pointed pieces in the line for better health, and I think I'm losing it of how I'm actually trying to ask it, but obviously it's not just a one size fits all, and there's multiple things that can go into affecting a person's health. How do you look at that when you're looking at health equity and social democracy within the book?
Yeah, I mean, so it's very complicated. It's complicated just in that the inputs to good health are very complicated. It's also hard to study because things occur over a long time frame, and that's just difficult to do. It takes time and effort, and things change. And it's hard to separate out other changes and things like that. So definitely very complex. Fundamentally, I think the way that we produce health equity is we produce social conditions that put people in what I call in the book relationships of equality with each other, where our status as individuals in a country is relatively equal. That doesn't mean that there aren't some hierarchies in specific situations. I go to work and I have a boss. There's a hierarchy there. Some people are voters and some people are the senators and Congress people and those kind of things. So there are hierarchies there. But in general, what what I think we should try to do, and what I think would improve health equity, is put people in situations where sort of everyone's life counts. Everyone has the conditions that they need to be healthy and pursue their conception of a good life and those kind of things. And I sort of focus in on four key areas. Again, you're absolutely right. There's no one single policy that's going to do this or anything, but sort of four key areas. One is a system of civil, political, and economic rights. So, things like the right to vote and free speech and things like that I think are just very important overall. I think that's the area where the U.S. is sort of closest to what we need. Not that there isn't backsliding, and we've certainly seen lots of attacks on voting rights and other things recently. So there's more work to be done there. But overall, I think our system of sort of liberties and freedoms there makes sense. The second piece, I think, is we need a system of income support, similar to what I was talking about before. That could be, a UBI way. It could be a social insurance way. I actually, in the book, make a slight argument for a social insurance approach over a UBI approach, but I think either would be better than the status quo, and both are normatively justified. The third is, I think, we need to think seriously about the labor market. For those of us in the working world, this is a real, source of power and contestation in our lives. And we've seen a lot of things like the decline of unionization and sort of rise of corporate power and commercial determinants of health and those kind of things that I think have serious impacts on health. And so I think we need to think seriously about how to, counteract that. Things like unionization, sectoral bargaining, and those kind of things, regulations like minimum wage laws and those kind of things. And then finally, I think we need a tax system, both that sort of finances this, so it makes the programs feasible, but also works against sort of unjust concentrations of power and resources that make it hard to put the policies in place that we need. So those are sort of the four areas where I think if we made improvements, we would at least over the long term see major improvements in population health.
Well, fantastic. Thank you for validating my muddled question. I appreciate that.
Yeah, no worries.
Seth Berkowitz, author of the new book, Equal Care, Health Equity, Social Democracy, and the Egalitarian State. Thank you for joining us today on Health Affairs This Week. And thank you, listener, for listening. If you enjoyed this episode, send it to the health economist in your life. I think they'd appreciate it. And with that, have a great week and have a great weekend. Thanks.